So this got it is coming on from the screen.
You can share the screen. You were sharing it.
So some got it message is coming on the screen. So wait a minute.
Oh, that was for recorded. You can click on that.
It's not going on.
If you click the got it, I also had this message.
Yes, sir. Got it. Can you
So we are able to see your presentation, sir.
Okay. Good evening, everyone. Today I'm presenting a case. Informant is the patient himself, and the history was taken on the third day of the admission. He's a 34-year-old male, educated up to 12th standard, businessman by occupation, resident of Delhi, who presented to our hospital with the complaints of headache for 3 days and blurring of vision from left eye from 3 days. The patient was apparently all right 3 days back when he started having headache, which was generalized, moderate to severe in intensity, and it got relief for few hours by taking painkiller medications. This headache was associated with blurring of vision from left eye, which was also acute in onset, non-progressive, and it was not associated with pain or any redness of the eyes. With both of these complaints, there was no history of fever, vomiting, loss of consciousness, any limb weakness, abnormal movements of any body parts, or any history of trauma. Patient also gives history of intermittent headache from last 4 months, 1 to 2 times a week, but not of such severe intensity. He used to take some painkillers for the same, and it used to get relieved. This headache was not associated with palpitation, increased breathing. There was no history of any history suggestive of proximal muscle weakness associated with headache. And for this headache, he did not underwent any checkup for the same in last 4 months. With this complaint of headache and blurring of vision, he was reviewed by an ophthalmologist and he was advised some eye drops, but there was no relief in his symptoms. During this checkup, he was also found to have blood pressure of 210 by 120 millimeter of mercury, and he was further referred to a hospital for admission. He was admitted in a hospital on 17th of August, which is around 1 week back. And as per the patient, he was admitted in ICU. He received some medications for his blood pressure control and also underwent CT and brain investigations. Patient was told that he's having during his blood checkup, he was told that he's having some deranged creatinine and he's losing some urine in his protein, for which he was advised kidney biopsy, and he underwent kidney biopsy on 19th of August. There was no history of, during last 4 months, there was no history of any decreased urine output, cola colored urine or gross hematuria. No history of frothy urine or swelling of any part of the limb. There was no history of joint pain, rashes, photosensitivity, oral ulcers. There is no history of recent upper respiratory tract or GI tract infections, no cough, shortness of breath, recurrent ear infections. There is no history of any hearing problem either. And there is no history of any loss of appetite, weight loss, nausea, and no history suggestive of any nocturia.
So, Shashank,
Yes, sir.
if you were to sort of analyze this history, if you were the physician, so what kind of illnesses are you talking about here?
So it seems like some chronic illness, sir, because he's having this headache from last 4 months,
Okay.
and now which has presented with an accelerated hypertension, most probably with hypertensive urgency in form of end organ damage with eye involvement.
Okay. So you feel that that this is a patient who is hypertensive, and the current problem seems to be related to accelerated or malignant hypertension. He has decrease in the vision in one of the eyes. He's gone to an ophthalmologist, but they haven't given any eye examination findings. That you only know that he was given some eye drops which didn't help him.
Yes, sir. Yes, sir. He was only given prescribed some eye drops, sir.
So we don't know whether there were eye findings. What were the eye findings on the fundal examination? Okay.
No, sir, not at that time.
Not at that time. So, but that would be important, isn't it?
Yes, sir.
So you think he's been also told that he has got some protein in the urine and he's
Yes.
got some renal dysfunction, isn't it?
Yes, sir. After admission in our hospital,
Yeah.
when he got admitted, he was told that he's having some protein in the urine and some increase in creatinine in form of deranged creatinine.
So now would that sort of help you to increase your diagnosis?
Yes, sir. It indicates some renal parenchymal disease, sir. With mostly that is the cause of secondary hypertension in this patient.
So one possibility could be that there may be an underlying kidney disease because he's been giving you a history of 4 months history of headache. So his hypertension may have been there at least for last 4 months, if we were to believe that that's the reason for his headache. And then this may be that there is an underlying kidney disease, and now that blood pressures remained uncontrolled and becomes accelerated, and therefore now he presents with accelerated hypertension. So that's one possibility. But could it be just primary hypertension?
So, considering the age of the patients at 34 year of age of onset of hypertension, and with the proteinuria in the urine, so it looks like unlikely to be primary hypertension, more suggestive of secondary hypertension, sir.
Yeah, but hypertension by itself can cause severe hypertension of this degree, can cause proteinuria and renal dysfunction, isn't it?
But sir, primary hypertension generally there's less likely of this magnitude of accelerated hypertension, primary hypertension, more commonly secondary hypertension.
Yeah, I agree that may not be, but primary hypertension still remains a common cause. I agree he is young, 34 years, and therefore one should be looking at probably secondary causes of hypertension. You need to rule out before you label him. But when you are thinking at the point of history, I would not be able to rule out hypertension. We can look at as to the cause, but hypertension producing this hypertensive nephrosclerosis, isn't it?
But that should be a long-standing hypertension, sir. Considering the only 34 years of age with
hypertension. Presentation of hypertension by itself, about what degree of primary hypertension can present as accelerated hypertension? What percentage of people? When you look at hypertension as itself, what percentage of hypertensive patients can present for the first time with, it's not very large, but there is a percentage of patients who can present with accelerated hypertension for the first time. Anyone else? Yeah, about 10% of patients, 5 to 10% of patients. Actually, in one study, probably about 7% of patients long-term. These are older studies where they were looking at the incidence of various presentations of hypertension, and about 7% of patients in that study, probably. I don't remember exactly the study, but it's been a long time. But 7% can present as accelerated hypertension. Not very. Uncommonly, yes, they can. And they may present with accelerated or malignant hypertension, can present with renal dysfunction, some proteinuria. And even nephrotic syndrome has been described as a part of malignant hypertension. Small percentage, but can happen. Even renal artery stenosis presenting as severe hypertension has been documented to present with nephrotic syndrome. So nephrotic syndrome also can be a manifestation, but yes, it's not something that you and I see every day, and that's true. And I agree with you that secondary hypertension would be primarily on our mind. But at this point of time, I would still want to keep hypertension as a background and try to look if there is a secondary cause. If there isn't one, then even a primary hypertension can present at this age and may manifest itself with a renal disorder. We'll get over. But thought process as such. Any other thing that you can think of?
So, acute nephritic syndrome, sir.
Yeah, acute nephritic syndrome. But if he has 4 months of hypertension, then acute nephritic syndrome, and he has no other manifestations, at least at this point of time. He doesn't talk of an oliguria, he doesn't talk of hematuria, he doesn't talk of edema and hypertension in an acute nephritic syndrome. Maybe hypertension would be secondary to the edema and the features. So he has at the moment nothing to at least suggest from the history. We've not yet gone even to the examination. We just know that there is some renal dysfunction and there is some proteinuria. Yes, some underlying kidney disease would have to be kept in mind, but we could go about it.
Yes, sir.
Okay.
Shall I proceed?
Yeah.
Okay. On past history, there is no history of similar episodes in the past. The patient is not a known case of hypertension, diabetes mellitus, obstructive sleep apnea, hypo or hypothyroid, or any other endocrine disorder. Personal history, he is unmarried. There is no history of smoking or alcohol intake. His appetite is normal and there is no any bowel and bladder complaints. Family history, there is no history of hypertension or any other kidney disease in the family members. Also, there is no history of any kidney disease on the maternal side.
Yeah, go ahead.
Coming up to journal examination, which was done on third day of the admission of the patient. On examination, patient was conscious, alert, and was lying comfortably on the bed. His height is 168 centimeter, weight around 70 kg, and BMI comes out to be 24.22 kg per meter square. Pulse is 90 per minute, which is regular. Volume was normal, and there was no radioradial or radiofemoral delay, and the condition of the blood vessel was normal. Blood pressure was 134/84 millimeter of mercury in the right arm, and there was no any significant difference of the blood pressure in the upper limb and the lower limb. Respiratory rate was 18 per minute, which was abdominothoracic, and there was no pallor, icterus, cyanosis, edema, or palpable lymphadenopathy of clubbing on examination. There was no evidence of any tremors, abdominal striae of thinning of skin, whiteness or xanthelasma. And on fundus examination, it was suggestive of bilateral multiple soft exudates and hemorrhage in both the eyes.
Yes.
On systemic examination, the higher mental function was normal. On central nervous system examination, his higher mental function was normal. Visual acuity, finger pointing was normal. There was no motor, sensory, or cerebellar deficit on examination. On abdominal examination, inspection, palpation, percussion was normal, and there was no evidence of any abdominal bruit. Cardiovascular and respiratory examination were within normal limits.
Okay.
On urine routine examination, it was suggestive of proteinuria of 2+, and RBC was fulfilled.
So now you have the examination and the history given to you. His blood pressure at the moment is now controlled, probably on drugs. And he has 2+ protein, full RBCs, no CAS.
No CAS.
Okay. So you have summary here. Yes, you can go ahead with the summary and then we can look at the causes.
Yes, sir. So he's a 34-year-old male with history of headache from last 4 months and presented with an hypertensive emergency associated with grade 3 hypertensive retinopathy. And on evaluation was found to have proteinuria, microscopic hematuria, and deranged creatinine, and has underwent a native kidney biopsy for evaluation of same.
Okay. So now can we go ahead with the possibilities that you are thinking of at this point of time?
Yes, sir. In differential diagnosis, I have kept my first differential as acute kidney injury on chronic kidney disease, being acute factor being accelerated hypertension, and chronic factor most probably chronic glomerulonephritis, in which I would like to rule out IgA nephropathy and membranoproliferative glomerulonephritis. Also, although unlikely, considering the male and no history suggestive of extrarenal feature, but still I would like to rule out secondary glomerulonephritis in form of lupus nephritis. Second, I want to keep my differential as acute nephritic syndrome, and of course there is a hypertension emergency with the grade 3 hypertensive retinopathy.
So would you like to defend your diagnosis of acute nephritic syndrome, second possibility?
Sir, it's unlikely because that's why I've kept it second diagnosis, because there is no evidence of any edema, there is no evidence of decreased urine output, there is no history of any hematuria either. But because there is hypertension and some evidence of proteinuria with high, so that's why I have kept it as second number. So.
Yeah, but acute nephritic would be, from clinical picture, it would be extremely difficult to defend this diagnosis of acute nephritic syndrome. Because there isn't any feature that you tell us about acute nephritic syndrome, isn't it? There is not a single feature except that this patient is hypertensive, presents with severe hypertension, and had changes in the eyes which suggest of grade 3 hypertensive retinopathy. So it only tells that there is a severe hypertension which is there for some period of time, and that's what is there. But there isn't any other evidence except for the urinary findings. There isn't anything else to suggest clinical syndrome, and acute nephritic syndrome is a clinical syndrome. So he does not fulfill any of the clinical characteristics of an acute nephritic syndrome. There's no prior history of any fever, anything to suggest, say, a viral or a bacterial infection which led to an acute nephritic syndrome, at least in there. So there isn't. So I would probably not, the biopsy might show something else, but unless you are aware of the biopsy findings, which might probably make you think of an acute nephritic syndrome. But I would, from clinical history that you're telling me, then I don't think that one would keep a possibility of an acute nephritic syndrome. I think your first diagnosis is okay. Acute kidney injury. Acute kidney injury is related to hypertension, accelerated hypertension, and that's leading to some deterioration, probably may have led to deterioration of his kidney function. And so chronic kidney disease is fine because you give a history of 4 months
Headache, sir.
of headache. So possible, and he has urinary findings. So probably a glomerular disease. But would you be able to rule out totally an interstitial kind of a disease, maybe a dystrophic kidney, which led to hypertension, may have some RBCs related to RBCs, and see his current urinary findings may not reflect his underlying disease, because the current urinary findings may have been produced by a severe accelerated hypertension, and which may have led to an acute deterioration, and maybe there is some fibrinoid necrosis in which has led to some RBCs. And so current urinary findings may not be, but somebody at 34 years of presenting with hypertension and maybe renal disease, would you keep possibilities of other causes of hypertension in this age group?
Yes, sir. Other causes of secondary hypertension should be ruled out. But on like on history, there was no history suggestive of other hypertension of like endocrine causes were not there on history, and also the renovascular causes. That the presentation is because of
Yeah.
gradient creatinine, the RBC and protein in urine. It itself rule out renovascular cause.
But
So
interstitial disease?
interstitial disease, he's not giving any history of any drug intake from the long time and anything which can damage the interstitium with long term. That's why I have not kept it as a interstitial, chronic interstitial disease.
Okay.
And also with the evidence of this RBCs and again protein. So then hypertension again.
If I now tell you to do an ultrasound and you find that his one kidney is small, shrunken.
Yes, that can happen. So one kidney.
On an ultrasound, now you come up with that the kidney is small, shrunken, so he could be born with either a dystrophic kidney or a vesico-ureteral reflux in the early childhood, leading to
Acute.
so some abnormalities. Although there isn't anything, he's grown into a tall individual, I think, and his height parameters and although don't suggest that. But I mean, in the broad category of discussion, I think you shouldn't be surprised on investigations that this is what may come up. So I think it's always good to keep your possibilities at the time of history taking broader. Physical examination may narrow down the diagnostic possibilities to some extent. And then investigations may further narrow it down to 2-3 possibilities till you get into the other detailed investigations and then narrow down to a final diagnosis. I think your algorithm for making a clinical analysis of your history should keep, the general pattern should be to keep your possibilities larger number of possibilities, although they may look unlikely. Like you said, on history, acute nephritic syndrome, okay, but physical examination and all others would rule that out. So that would help you to get rid of it, acute nephritic syndrome. But I would not be able to rule out an underlying. So at the moment, I will keep other causes of hypertension as well. I will like to rule out, since it is narrowing down to a renal associated hypertension, probably because of the urinary findings that he has. So it appears that probably I'll have to keep all other possibilities which could cause hypertension. And the current urinary findings which make me to think of a glomerular disease may be related to hypertension itself. So I will have to keep that possibility also, so that I am not surprised. Would you agree with that, or you feel that that's too far off the cuff?
I agree, sir.
So you are okay with that possibility that,
yes, sir.
Let's see, there is Vivek Goel ji, dysmorphic RBCs. He's talking of. So did you do the urine examination yourself?
No, sir. This is lab investigation, sir.
And they haven't mentioned anything about the dysmorphic RBCs. And I think that takes us to this question of when you see RBCs in the urine, so where all can these RBCs come from?
So it can be a glomerular cause of RBC, sir, or it can be from the tract, sir. So when they come from the glom, they are dysmorphic. They get dysmorphic because of the shape of the RBCs, because they are not able to pass through the glomerular filter membrane. And when there is a tract is the cause, so they are not dysmorphic; they are isomorphic, sir. And that's the difference, sir.
Yeah. So percentage of dysmorphic RBCs will surely tell you about. So would this, what about proteinuria being part of hematuria? So how much of proteinuria can be explained by hematuria?
Sir, up to, I'm not sure, up to tubular range of proteinuria, maybe.
No, I'm talking of, see, you have RBCs in the urine, and whenever you see red colored urine, now you have also protein 3+, 4+. Now, so somebody might say that because there are red cells in the urine, there will be some degree of proteinuria because of the hematuria. So in patients with hematuria, which is, you have a proteinuria of 200 milligram, you have a proteinuria of 4 grams. So you think proteinuria of 4 grams could be explained by hematuria itself?
No, sir, it is nephrotic range proteinuria, so not explained by only the presence of
Red cells,
RBC.
RBCs. So yes, RBCs, actually very small amount of RBCs are required. 1/3 of a microliter of an RBC is required to produce hematuria, isn't it? So to give color to the urine itself, which is visible to the eye itself. So when a patient looks at the urine and it looks red colored urine, except that if there is frank blood in the urine, which comes at clots, but otherwise red colored urine, the amount of blood that you require is 1/3 of a microliter to produce that kind of color to the urine. It's like you drop a drop of blood in a bucket of water, it gets colored red. So very small amounts of blood. So that amount of blood will not be able to explain the amount of proteinuria. So whenever you have nephrotic range proteinuria, then that proteinuria tells you about the glomerular origin of proteinuria. And that means there has to be a good possibility of glomerular membrane being affected by a disease process which is causing proteinuria. So many times hematuria may sort of be a confounder for proteinuria, but that's never a confounder for proteinuria of a nephrotic range proteinuria. So it can explain maybe smaller amounts of protein in the urine, but cannot explain large amounts of protein in the urine. So that's while we were at the urine examination, and I think that's important. So I think instead of acute nephritic syndrome, I would try to keep the possibilities of other renal disorders, maybe acute or a dystrophic kidney or vesico-ureteric reflux leading to a smaller kidney, and producing hypertension can produce accelerated hypertension. And that can also explain that this hypertension and the current urinary findings may be as a result of the accelerated hypertension that he has, isn't it? So that would be a reasonable possibility. Anyone else has any other possibility at this point of time? If they can put it in the chat, or Puneet, can we get them to speak also or no?
Yes, sir, they can, sir. They can just unmute themselves and speak.
Yeah. Anyone wanting, can we? Anyone wanting anything? If not, then okay, Shashank.
Yes, sir.
Is there anything else that you would want to say about him at this point of time?
No, sir. I want to move to investigate him further, sir.
Okay, you would. So at this point of time now, we are looking at a glomerular disease. We're looking at some interstitial causes as such for kidney disease. And obviously he seems to have some dysfunction related to accelerated hypertension. Go ahead.
Yes, sir. So we then investigated this patient, and these are his blood investigations. His CBC showed normal hemoglobin. His LFT albumin was
No. The normal hemoglobin is that of some help in?
Yes, sir. Because I was like considering chronic kidney disease, so I was expecting a low hemoglobin, but it has come up normal. So
yeah. So it tells that probably at least renal dysfunction may not have been very severe.
Very long
for a long period of time. So it is, I think if at all his renal dysfunction may have occurred and it is severe, then it is probably of a shorter duration, not of a long duration of chronic kidney disease, isn't it?
Yes,
at
sir.
least this is what this investigation helps us to tell us. Okay.
Then his platelets and ESR was almost normal. So
Okay.
I can expect thrombocytopenia in lupus. So although only suggestive, but no evidence of thrombocytopenia. In the
Okay.
liver function test, the total protein is normal. The albumin ratio, AG ratio is maintained, and the total albumin is normal. So it also suggests whatever disease that's not very long standing because the albumin is normal and
Or the degree of proteinuria is also not very,
not severe.
not
Right.
severe and not high. Probably he may have had a proteinuria. So one will have to look at diseases which do not cause very heavy proteinuria. So if you were to look at the possibilities that you kept, IgA probably would be okay. MPGN, you should have probably higher
Nephritic.
amounts of proteinuria. So if at all one has to look at the possibilities till this period of time, IgA may be okay, if at all he has, and that may not have caused severe renal dysfunction at this point of time. Okay.
Coming to renal function test, sodium potassium were normal. So potassium helps me ruling out, although I've already moved on to secondary cause of hypertension with renal parenchymal, but still normal potassium helps me to rule out this Conn syndrome, primary hyperaldosteronism.
Right.
Then presentation creatinine was 2, and then when we did the biopsy, the day of biopsy, the creatinine was 1.7, and his electrolytes were normal.
Yeah, I think this also probably helps you that there is some acute dysfunction because his kidney function to start with was higher and is started getting a bit better as the blood pressure has shown better control now and improvement in blood pressure. And that is what is the acute kidney injury part, which probably is related to hypertension.
And we did 24-hour urine protein, which was subnephrotic. It was around 2.5 gram in 24 hours. Immunological workup, ANA, C3, C4 were negative. And patient was not admitted under us. He was actually admitted under neurology team. So that's why serum cortisol and 24-hour urine catecholamine were done by them, which were found to be normal. He was found to be hyperthyroid, and TSH was around 38.4. Viral markers, hepatitis B, C, and HIV were negative.
Ultrasound?
Yes, sir. Moving up to radiological investigation, ultrasound showed normal size kidney. Right kidney was 9.6 centimeter, left kidney was 10.9 centimeter, and there was evidence of bilateral increased cortical echogenicity, although the corticomedullary differentiation was well maintained. Renal Doppler was again done by the neurology team, which was found to be normal. He also underwent CT brain and MRI brain, which were suggestive of hypodensities in the temporo-occipital, cerebellar, and frontal area, most probably suggestive of this reversible encephalopathy syndrome with accelerated hypertension. He also went 2D echo, which was suggestive of mild concentric left ventricular hypertrophy. So from these investigations, two findings of increased cortical echogenicity and mild concentric left ventricular hypertrophy suggest some long-standing, most probably renal disease and long-standing hypertension. So these are the positive findings from these two, including the acute evidence of Press syndrome from MRI brains.
Right.
And then we did the kidney biopsy, and on the light microscopy showed 6 glomeruli, of which few showed segmental mild mesangial expansion with the minimal mesangial hypercellularity. In addition, 2 of the 6 glomeruli showed segmental sclerosis. There was no evidence of diffuse mesangial hypercellularity, no necrotizing lesions, no endocapillary or extracapillary proliferation. Tubulointerstitial compartment shows around 30 to 35% of tubular interstitial atrophy and interstitial fibrosis. And vascular compartment was showed the evidence of hypertensive changes in form of few arterioles showing circumferential arteriolar hyalinosis. On immunofluorescence, mesangium was IgG A3 positive, and other IgG, IgM, and other markers were almost negative, not significant.
The biopsy also showed lambda 3 plus.
Were 3 plus. All these were C3 and lambda were all in the positive, only in the mesangium.
Yeah.
So this biopsy showed me that it is most probably suggestive of IgA nephropathy with acute evidence in the form of there's no any acute evidence of any like acute activity is not much there, but in the chronicity there is segmental sclerosis and around 30 to 35% of IFTA is there with the evidence of some hypertensive changes.
So it only sort of suggests, this biopsy suggests that the IgA disease must have been there for some period of time, and he hasn't had any clinical symptoms, which could have given him a clue towards this. And he obviously didn't get a urine examination done until he presented with accelerated hypertension. And that's what made him to come to a clinic for getting himself treated. So this is what can happen in these kind of diseases. And we usually pick up IgA disease, at least in our country, quite late. And this is again an advanced IgA nephropathy. Can you, on this biopsy, explain to me why is this? Would you consider this as there is restriction of lambda and the kappa is trace? So would you consider this as a MGRS also, or no?
Sir, unlikely, sir, because it was only in the mesenterium, sir. They were positive only in the mesenterium, and also no evidence of any cast was there, and further.
Now, would you say this is something usual in this biopsy, or this is unusual in this biopsy?
So generally, when we see this IgA nephropathy, they say that we can find lambda chains.
Yes, that's exactly what I wanted you to express. Actually, that lambda chain expression is much higher in IgA nephropathy, and usually, so it should not make you think of an MGRS or monoclonal gammopathy syndromes in this kind of a situation. This is not common. This is not similar to what you find in other findings of glomerulonephritis, where there will be kappa and lambda will be equally shown. So there will not be lambda restriction. It's only in IgA nephropathy for some reason they have a greater expression of lambda chains, and that's something which is very, very consistent with the diagnosis of an IgA nephropathy. That's what I wanted you to say. Okay. So now your final diagnosis is?
So coming up to final diagnosis, sir, acute kidney injury on chronic kidney disease. Considering the GFR of 1.7 at age of 34 hits, estimated GFR was around 52. So stage 3 CKD. Acute factor being accelerated hypertension and chronic factor being chronic glomerulonephritis, most IgA nephropathy, which on biopsy Oxford MESI score is M0, E0, S1, T1, and C0, and associated with hypertension with grade 3 hypertensive this is grade hypertensive retinopathy, both the eyes, and posterior reversible leukoencephalopathy syndrome with hypothyroidism.
Yeah, that makes it, I think your clinical impression about this patient seems to be that this is an underlying kidney disease, and he presents with hypertension, and hypertension as a presentation of an IgA nephropathy is again unusual, not that you will see it. And nephrotic syndrome, although he didn't present with that kind of syndrome, but that's also again unusual, occurs in 5 to 7%, 8% of patients with nephrotic. So accelerated hypertension itself as a presentation would again be an unusual feature, but then that's the way diseases don't read books, so they can present with different presentations, and in this is an interesting presentation of an accelerated hypertension. And that only shows that if you have blood pressure which has not been controlled with drugs, or people are not, where they continue to have uncontrolled hypertension of longer duration, this hypertension, whatever the cause, will become an accelerated hypertension. And then this is a sort of a vicious cycle. Increased blood pressure causing more damage to the vessels, increasing the blood pressure further. And this chain, unless you break this chain, this will not be broken. It's a vicious cycle of kidney disease causing hypertension, and hypertension increasing the severity of kidney disease, and this process goes on. So it's extremely important to break this chain before you can sort of see that the kidney function reverses or gets better. At least the acute components of the kidney dysfunction get better, as is seen in this patient. And you see all the other manifestations of hypertension in this patient. Left ventricular hypertrophy, you see also evidences of grade 3 hypertensive retinopathy in this patient with exudates and the retinal changes, the vascular changes in the retina, as well as you see the posterior reversible posterior encephalopathy, which is known with accelerated hypertension, except that he didn't present with severe neurological syndrome, but some of them can present with severe. And can you tell me what are the other features of reversible posterior leukoencephalopathy syndrome?
Yes, sir. Altered sensorium, seizures with the involvement of occipital lobe. There could be a vision hallucinations could be there, sir. With the temporal lobe involvement, there could be this smell issues could be there. With frontal lobe involvement, there could be personality changes, sir.
Yeah, so there could be multiple manifestations of this syndrome with severe hypertension, and these are usually, fortunately, reversible in most patients, but in some patients may lead to infarcts, and they may be left with some irreversible damage depending on where the infarcts may be. So they could be in the visual area, they could be in the temporal areas, or they could be in the frontal areas. Yes, they can be left with some infarcts and some irreversible damage to the brain, usually called reversible. Most often it is reversible and usually recovers. What are the other causes of severe accelerated hypertension? One is the renal disorders. You said that renal parenchymal disorders can cause this. What
Yes.
else?
Renal vascular disorders.
Renal vascular disorders.
Then there'll be endocrine disorders, which primary hyperaldosteronism.
Primary hyperaldosteronism would be again another one, usually characterized by low potassium,
metabolic alkalosis,
and metabolic alkalosis, and
pheochromocytoma.
Yes,
Cushing syndrome. Hypo or hyperthyroid both can present with malignant hypertension. Obstructive sleep apnea can also be there. And sometimes drug intake, although rare causes, but NSAIDs, cocaine abuse, antidepressants, and when we use this CNIs.
Yeah, calcineurin inhibitors, and I think that's important. So they can present with severe hypertension. Especially, which kind of situations would you see this?
Post-transplant CNI toxicity, sir?
Post-transplant can occur, but you see it more often in which kind of patients?
Sir, which are taking other drugs which may inhibit the metabolism of CNI?
Yeah, actually in patients who have renal failure. So when you do ABO incompatible transplants and you give, you start immunosuppressive drugs before you start treating them. So you start usually 2 to 3 weeks before the date of transplantation in an ABO incompatible transplant. So usually about 2 weeks. And they have renal failure also. These patients are on dialysis, or if they're undergoing preemptive transplants, then their renal function is still a creatinine of 4 and 5, GFRs less than 15. So these patients, when you start giving them calcineurin inhibitors, they produce severe hypertension occasionally and can cause posterior reversible. So this has been documented, especially when you use this, these kind of drugs, or when you are giving calcineurin inhibitors in patients with severe renal disease as a treatment, say membranous or other glomerular diseases where you want to give calcineurin inhibitors as treatment, and they have renal dysfunction as well. So in those situations, again, also they can cause severe hypertension, and you might have reversible posterior leukoencephalopathic syndromes occurring in these patients. Much more, you don't see them. You can see them in post-transplant period as well, but not as common as you see them in patients of other renal diseases where you use calcineurin inhibitors and renal dysfunction or blood pressures are fairly high in these patients. So those are the situations where you should keep that possibility. Okay. So how will you go ahead and manage this patient now?
I would like to start this patient of non-immunosuppressive medical management.
So you would not consider him for immunosuppressive drugs?
Not right now, sir, because he's like first presentation. First, I would like to start him with non-immunosuppressive medical management with blood pressure control with ACE inhibitor for ARBs, and other dietary lifestyle management with salt restriction, exercise. So weight is almost okay, so regular exercise. So that will be my first plan for management for him, sir.
So would be effective control of blood pressure. And what would be the drugs you will use for control of blood pressure?
RAS inhibitors, sir, ACE inhibitors or ARB, telmisartan.
Would be your drug of choice. So out of the RAS inhibition, what would be your preferred, ACE or ARBs? How do you decide whether you choose an ACE or an ARB?
I will prefer. I will prefer ARB, sir, because although the trials, some trials have also shown that ARBs are much better, and the cough, considering the side effect of cough with the ACE inhibitors, so ARBs will be my first choice over.
Your ARBs would be. ARBs, by and large, produce very little adverse effects. So extremely friendly drugs for patients, because the adverse effects are extremely on the lower side, which patients perceive as adverse effects. Obviously, RAS inhibition has some adverse effects which the nephrologist or the physicians would look at, but for patients, by and large, they remain relatively asymptomatic with the ARBs. And out of the ARBs, losartan, telmisartan, olmesartan, valsartan, which would be your prefer? You said telmisartan. What do you think telmisartan would be your drug of choice?
Because I'm not I don't have any evidence to prefer any ARBs over one of the other. Just that
I have. I also use telmisartan, but there has to be a reason to use telmisartan. So why would you think?
I'm more comfortable with telmisartan.
Why? Why? Because
cheap,
why
very
do you
cheap,
think?
cheap, easily available, and
but any specific reason why would you use? How would you choose which out of these? This would be commonly asked if you present a CME on blood pressure management or renal disease with hypertension, and you were to present to physicians, they would ask you this question. So this is one of the common questions asked, that would you prefer an ACE or an ARB, and why would you? And they consider nephrologists to be experts on RAS inhibition, so they would definitely want a good answer from you for this. And so I thought you should know as to how you pick up these drugs as such. So you would want a drug, basically, which should be cheap, a drug which shouldn't be very expensive. You should choose a drug. We should have a long duration of action, because you want blood pressure to be controlled 24 hours, isn't it? You would want a drug which has a long duration of action. So you would choose a drug which has a long half-life. So you can use it either once a day or at the most, maybe twice in a day. So you would use a drug. So if we were to look at losartan, so what's the duration of action?
So it's around 6 to 8 hours.
Yeah,
So we have
6
to
to
give
8 hours. So you should be able to, you have to give it 3 times a day. So giving losartan 20, I see many prescriptions, losartan 25 milligrams in the morning. And so that's not a good drug to produce effective, continuous, long-term control of blood pressure, isn't it? Because this drug pharmacologically is supposed to be acting only for 6 to 8 hours and therefore will not produce good, effective blood pressure control, which you and I want for our patients. If there is one factor which is important for reducing the progression of kidney disease, that's hypertension. Number one reason. Whatever the drug could be control of blood pressure by itself, and then the choice of drugs. ACE and ARBs, so RAS inhibition inhibitors, become the drug of choice, especially with proteinuric renal disease. So they would be the best. So losartan doesn't have it. Well, then we talked of valsartan. Valsartan has a duration of action.
valsartan is it is a like we can give it once daily, sir. But valsartan is very costly, sir.
Valsartan is an expensive drug, so it doesn't fulfill that. Yeah, but the problem with these drugs is that out of valsartan is a long-acting drug, olmesartan is a long-acting drug, and telmisartan is a long-acting drugs. So, but when you look at the duration of action of these drugs, I think olmesartan probably fulfills the longest, which is once a day, 24 hours. But they start, if you look at their duration of action, the peak action and the tail off. The tail off occurs if you take telmisartan in the morning, the tail off will occur sometimes early morning next day. So then 4 or 5 hours in the morning, by the time you take the next dose, will have poor blood pressure control. Especially with valsartan, that this time may go on for 6 to 8 hours. If you take one in the morning, and therefore, if you have to give it once only, what time would you give RAS inhibitors?
At night, sir.
At night, yes. If only one drug is being given, then use this drug. Why do you do that?
So to prevent this, hypotension can be prevented, and compliance is also comparatively better at night.
Any other reason?
Um, if I give it at night, it will help in maintaining the blood pressure throughout the next day until the patient takes it again at other night.
Yeah, there could be an evening. Still, there could be a tail off in the evening if you give it one. But why is it that the morning blood pressure should be good? You want the morning blood pressures to be good, especially morning blood pressure.
Because there is a they say that this high risk of stroke.
Yeah, stroke, myocardial infarction, all the risks of hypertension, be it primary or be it secondary, occur in the morning, highest in the morning. And so therefore, if you have to give just one drug, your aim should be 24 hours blood pressure control. And that's the reason why a long-acting drug like telmisartan, which ordinarily should be okay for about 24 hours. But as I said, that there is a tail off of about 3 to 4 hours. With telmisartan, it is 3 to 4 hours probably. With valsartan, this is about 6 to 8 hours. With olmesartan, probably maybe 1 to 2 hours. This tail off, when the peak effect goes at 12 hours and then the effects start dwindling. And in the last 24 hours, 22 to 24 hours for olmesartan, and maybe 20 to 24 hours with the telmisartan, that effect lasts. So I would give, if I have to divide and give telmisartan twice in a day, so that you have a peak effect at both times. So the morning has a peak effect in the evening, and the late evening drug has a peak effect in the morning. And when these tail off, the other is having a peak effect, isn't it? So using a drug which is a long-acting twice may be okay. But if you require once drug only, then I would give it at night, ARBs or ACE inhibitors similarly. So you would want a drug to be long-acting. You would, so for continuous, good, smooth monitoring of control of blood pressure. And you would use a drug which is not expensive and which produces the least kind of adverse effects. And so I think telmisartan fulfills that, and therefore is my choice as well. And I have used it for many years, so I know this drug much more than any other drug that I have is available on the. So that's the reason to use telmisartan in this. So I would optimize telmisartan. So how will you now keep on increasing the dose? You might start with 40 milligrams. So what are your two aims in this patient, which you want to tackle with telmisartan?
Yes, sir. First will actually three, sir. First will be the blood pressure control. Second will be the rising creatinine, which you have to monitor on starting telmisartan. Third will be the hyperkalemia. So these three things I would like to monitor on follow-up, sir.
Nothing else to be monitored? I thought there was another important element. So one is to look for adverse effects. Other is to look for efficacy. So for efficacy of telmisartan, so one is blood pressure control. Anything else?
Proteinuria,
Anything?
anti-proteinuric effects of proteinuria.
So what are the long-term effects of telmisartan in patients with chronic kidney disease?
So it helps in decreasing the proteinuria and it slows down progression of chronic.
Slows down. So as a nephrologist, you tell this patient that, gentlemen, I do not have a drug to cure your disease. He says, thank you very much, doctor. You look very, very promising to me. No, nothing to take care of this disease. So you also tell him that this disease, you can't reverse whatever damage has happened. Probably that's what you will tell him. Whatever acute recovery of hypertension may have to happen, but the disease that has caused some renal dysfunction in him is unlikely to reverse. So he's not again happy. So you have to give him some good news. And the good news is that RAS inhibition helps in reducing proteinuria. And reduction of proteinuria is important or not important?
Yes, sir, it is important.
Why is it important?
So reduction in proteinuria not only helps in slowing down the progression of ESRD, but also helps in long-term cardiovascular mortality. It's also decrease the proteinuria with.
So albuminuria reduction of proteinuria is associated with increased mortality. As per the heat map that you see of CKD heat maps, albuminuria on one side and declining GFR on the other side. Progressive decline in GFR, independent risk factor for mortality, and increasing albuminuria, an independent risk factor for mortality, independent risk factor for progression of kidney disease, independent risk factor for ESKD, independent risk factor for cardiovascular mortality. So you have both these. So you are interested in slowing down the progression of kidney disease, and there is good evidence to show that in patients who have albuminuria, there is very convincing evidence that RAS inhibition slows down the progression of kidney disease, and then decreasing albuminuria. So you have two targets. One, to slow down the progression, and second is to see that you will optimize telmisartan and increase the dosage, not only to control blood pressure, but to see that you optimize it to the dosages that you have progressive decline in albuminuria. So 2 grams to 1 gram, 1 gram to 500 milligrams. So it's important that you keep on reducing it to as low as possible. Is there evidence that reducing albuminuria improves the survival in these patients?
So long-term survival, I'm not sure, sir, about this. I'm not sure.
Long-term survival. What about ESKD?
Yes, sir. When we control the proteinuria, the progression to
Yeah,
ESRD
and
is
yeah,
sir.
and which study showed that?
This both the
Non-diabetic kidney disease, which study? Diabetes, there are many studies which looked at progression of kidney disease and overall survival as well. But non-diabetic kidney disease, can you name one or two diseases which looked at?
so with specific to IgA nephropathy, sir?
Maybe IgA or non-IgA, but non-diabetic non-diabetic kidney disease.
Sir, in IgA, both testing and the stop IgA trial both have showed
No,
that.
that is with, yeah, that's with the placebo arm, but testing and all these were immunosuppressive drugs, steroids. I'm talking of RAS inhibition, a decrease in albuminuria showing an improvement in non-diabetic kidney disease. Ryan study by Ramuzi, 2004. So they used ACE inhibitors in them and showed that the degree of albuminuria was associated with reduced progression of kidney disease and the doubling of serum creatinine. And that point of time, predominantly, those were the criteria which were used: doubling of serum creatinine or development of ESKD or death. And these were the criteria which were used, and they showed that effective RAS inhibition in a non-glomerular disease reduces albuminuria, and albuminuria reduction leads to less ESKD in these patients. So these become two markers for you to follow. And unfortunately, I must say that the reason why I'm spending some time on this is that when you see doctors or nephrologists in practice, proteinuria or albuminuria is not even done. Actually, this is not targeted. You don't follow these patients. Every time you see them, you should look at albuminuria, and you should target that. If your albuminuria is not gone down, then you should try to see whether I can increase the dose of telmisartan. The blood pressures may be okay, 130, 84, but if the proteinuria hasn't gone down, I would want to increase it by 20 milligram more if there is no hyperkalemia and there isn't any other reason for me not to increase the drug. Even though the blood pressure may be all right, 130, 80 is what you target, but it may be all right, but I haven't reached an effective reduction in albuminuria. And the least reduction in albuminuria should be 50% reduction, which has been documented to show improvement in survival in these patients. So I think the least I should be attempting would be reduction, and that should be followed in these patients. I think as nephrologists, we seem to be lacking in targeting albuminuria as a marker for our efficacy of therapy in our patients. So we seem to be bugged by creatinine. We look at creatinine, and then unfortunately, even small rises in creatinine are always considered to be due to RAS inhibition without any reason. RAS inhibition will cause increase in creatinine by hemodynamic factors, but those hemodynamic factors, unless they are present, there's no reason to reduce or decrease RAS inhibition in people with established kidney disease, just for the fear that the creatinine may have gone from 1.1, because patient is concerned about it. They are very much worried about the creatinine. Their life revolves around creatinine, but we fall prey to that and then reduce this drug, which is perhaps the only drug which at the moment has been effective in these patients, and you try to give drugs which are not of any use. So I think, so RAS inhibition is an extremely important element in the management of this kind of a patient. And I think it's a tool which should be very effectively used by nephrologists. And you must do everything which helps you to use this drug. So what is the other drug which you can use for reduction in proteinuria these days?
So SGLT2 inhibitors.
Yes, and SGLT2 inhibitors. And there is evidence, especially just 2 days back, I think the credence data which was looking at diabetic kidney disease. But the credence data also demonstrated that actually in those patients who were on RAS inhibition, SGLT2 inhibitors helped them to have reduced hyperkalemia. Incidence of hyperkalemia was much lower in those patients who were on SGLT2 along with RAS inhibition, with say inhibition, because so 80 to 90% of those patients on the credence trial were on RAS inhibition, and therefore SGLT2 helps you to effectively use both these drugs for reduction of albuminuria as well as it also slows down blood pressure control. It also slows down the progression of kidney disease, both in diabetic and non-diabetic kidney disease. And in the DAPA trial, CKD trial, there were fairly large number of patients with glomerular disease, membranous and non-diabetic diseases. So there was a group of patients, and IgA formed a significant group in these patients. So SGLT2 inhibitors would be another drug which could be added after you have optimally utilized and because RAS inhibitors will produce hyperkalemia. You said that there is a problem with hyperkalemia in these patients. So if hyperkalemia is there, then you can probably reduce the dose to some extent so that you have potassium in a manageable level and add an SGLT2 inhibitor to this. And fortunately now SGLT2 inhibitors are also becoming relatively less expensive. They're not as expensive as they were a few years ago. Now you have generics ones also available, and then even the original ones have become 50% of the cost they were available previously. So you can use SGLT2 inhibitors very effectively in this kind of a patient. So you would use telmisartan and an SGLT2. In addition, what about the nutrition? This patient has a creatinine of 1.7. He says he's a non-vegetarian guy and he is active otherwise. So what was his weight? You said that, I forgot.
70 kg, sir.
70 kg. So what kind of diet would you give?
Sir, low protein intake of around 0.8 milligram per kg because it's subnephrotic proteinuria, so no need to add extra protein. Calorie intake of around 30 to 35 kilocalorie per kg, and we should include total fat should be less than 35% of total calorie, and saturated fat should be less than 10% of that.
So how will you, he's a non-vegetarian guy. So can you make a diet for me? Suppose I am the patient and now you have to tell me, so how much of milk should I take and how much chapatis and what kind of dal, how much chicken. So can you tell me, give me a prescription of a diet?
No, sir.
You can't do it. Come on. Then what kind of a physician are you going to make? So what's the amount of protein in milk? What's the amount of protein in milk? 100 ml of milk contains what kind of protein? $100 ml of milk contains 3 grams of protein. Okay, all kinds of milk, be it cow milk or buffalo milk or human milk or other, all milks contain about, fats vary, but proteins are about the same, roughly 3 grams. So half a kg of milk will give 15 grams. For 70 kilogram, if you say 0.6 to 0.8 grams, and I usually calculate it for 7.7 grams per kilogram body weight. So for a 70, so it would be about 50 grams of protein, isn't it? So Indian diets usually are, most people are fond of milk by and large. So if you could give them half a kg of milk if they want, whichever way they want to have it, they could have it in form of, so that gives them 15 grams of protein. And it's a good quality protein also. When you reduce protein, then you need to give 50% proteins need to be high biological value protein. And these are available in vegetarian diet. They are available only in milk and milk products. Lentils and cereals have usually a moderate or poor quality proteins. They don't give you, and the biological value proteins have usually a high percentage of essential amino acids. And so therefore you need to give 25% of proteins must. So 50 out of 50 grams of protein, 25 grams must come from. So we can give him half a kg of milk and 1 katori of dal, moderate kind of thickness, will have what? 100 grams of lentils have how much of protein? ये तो भाई दाल चावल का हिसाब किताब बहुत कमजोर है. शशांक जी कैसे है? 100 grams of lentils contain general. I'll give you a general so that you will be able to practice it in 100 grams of lentils, all kinds of dals. By 100 grams of uncooked dal will be making about 16 grams of protein. And usually 100 grams will make of moderate thickness will make 4 katoris. So 16 grams. So 1 katori of dal will give you 4 katoris, 4 grams of protein. Okay. So general, you can ask your mom or your wife, if you're married, to tell you. If you aren't, you have a girlfriend, but the girlfriends will know how to cook. So, but if you ask your mom, they'll tell you that about 4 katoris in 100 grams of dal. So you'll have 4 grams of protein in the dal, but the dal and cereals, a person eats about, if he eats 4 chapatis in the morning, 4 in the evening, and then 1 or 2 pieces of bread in between, with a toast with morning breakfast and others, and some cereals and all that, will be about 200 grams. And 100 grams of wheat or rice usually contains about 6 grams, 5 to 6 grams of protein. So 200 grams, 150 to 200 grams will usually give about 10 to 12 grams of protein, isn't it? For calculation purposes, vegetables have very little protein. For calculation purposes, fruits have very little protein. So I usually don't add them up. They may give you few 2, 3, 4, 5 grams at the most, but I don't usually add them up. That quantity is extremely small. Again, a poor quality protein. So usually fruits and that. So now what you are left with is predominantly egg and non-vegetarian or cheese cheese for vegetarians. So egg contains 6 grams of protein. So 5 to 6 grams of protein. So if you eat 2 whites of an egg, then they will give you 10 grams of protein. 1 egg, white of an egg, calculate 5 grams of protein. Chicken, fish, and paneer. 100 grams of uncooked meat, uncooked. Take away the bones, will contain 25 grams of protein. Okay. So now you can make a meal for anyone, depending on whether he is vegetarian or non-vegetarian. Now, most of the components of diet, roughly as to how you calculate the proteins. And calories, obviously, you will have to add fat or carbohydrates, depending on how to increase the calories. Calories should be high in patients of chronic kidney disease. So I think every nephrologist should be able to guide their patients. And the reason why you need to guide your patients yourself to some extent is that by and large, the dietitians somehow carry the feeling that they need to restrict people to eat anything, and they don't allow them to eat anything. And they should be actually, most often they should be trying to help patients to motivate them to eat. But by and large, I find that when you send a patient to a dietitian, they usually somehow take away that joy of eating, and patients whatever they may be feeling like eating, they don't feel like eating anything. So I think it's very important for a nephrologist to know as to how to guide your patients so that they get enough nutrition. Salt is to be restricted, but essential spices, they can be taken. There's no reason why you should restrict spices. There's no reason why you should restrict nominal amounts of oils in these patients, ghee and mustard and other oils. So that food becomes tasty. If you cut down the salt and you cut down the oil and the spices, food is not worth eating. Even if you tell him to eat, he's not going to eat it. There's no way anyone is going to eat it for a long period of time. 2 days, 3 days, 4 days, you might fast, but you can't. So food has to be tasty, and you should be able to make them eat. The purpose is not to produce malnutrition. In India, chronic kidney disease, nephrologists including, don't allow people to. They tell them to stop milk, stop dal, and that's what people come with. There's no reason why should you stop. You have to make 50 grams of protein. Indian diets, even when you look at your own diet, you calculate your protein intake. Now you can do it for your own diet. So you calculate it and you will find that you're not eating 1 gram per kilogram body weight of protein. There's no way an Indian can eat that kind of protein.
Coming around only 20.
Fun?
Only 25, sir.
Yeah, that's exactly what I'm saying. So when you look at this kind of, then you know that probably your patients do not need that kind of restriction. And in fact, there is an ICMR study which looked at all the Indians sampled, about more than, I think it was about 20,000 samples across the country. And they looked at the protein intake in normal population. 9 out of 10 people were consuming 0.8 grams of protein per kilogram body weight, which is exactly what you were wanting to give to your patient, isn't it? So most of us are taking low protein diets in our, so there is in fact no restriction. Salt restriction needs to be done. And obviously if patients are prone to hyperkalemia and all that, so you need to tell them how to leach vegetables. Don't stop green leafy vegetables also. There is nothing. People feel that there is a high amount of protein in green leafy vegetables and therefore they need to, you need to tell them that it is because of the potassium that you're wanting these. Soak dals. Dal unko chilke wali nahi khani hai. When chilke wali dal mein potassium sugar zyada, to soak them in water. Let dals be soaked in water. Potassium is very easily soluble. It moves out of the cells, goes into the water, throw the water away in about 3 to 4 hours time and cook the dals and all that. Let him eat and enjoy all the dals. Why do you want to stop dals to these patients? Why do you want to stop milk in patients who are vegetarians and all? What will they eat? That's the reason why. See, people, doctors stop them. And on top of it, their family is so crazy. They don't let them eat anything. The creatinine goes up. That day they have to starve. They will tell them, wo kha liya tha, ye kha liya tha, wo kar liya tha. So be careful about diet, control of blood pressure. That's important. No, I am discussing these because these are not commonly discussed this way in the classes. You read books and books will not be able to tell you these practical difficulties which are present in patients. And you are forced to give keto analogs and all that. Where is the need to give keto analogs? If you give them, why do you want to give them 0.4 grams of protein? Where is the evidence that 0.4 grams of protein restriction with 6 tablets, 200 rupees per day treatment for a poor patient, Indian patient, and how many tablets? Is he going to eat food or tablets? So I would give him natural proteins as he can eat and enjoy in his life. Chronic kidney disease usually makes these patients, as such also, they're extremely depressed that they got kidney disease, which is not going to get cured. And on top of it, you make them extremely malnourished. By the time they come for end stage kidney disease, whatever you do transplant or you do dialysis, their outcomes are poor. And the outcomes are poor because malnutrition kills them. Mortality is much higher in people who are extremely malnourished in comparison to those who are better nourished and all that. So it increases mortality extremely high. So, and the other thing is that if a patient has become malnourished, there is no way you can make him better. So if he has fallen in the nutritional categories, to put back nutrition into the person is extremely difficult. So don't let people become malnourished. So catch them early. Once they become severely malnourished, it's not easy. You will require hell of a lot of effort from family, from doctors and physicians. Impossible to get back nutrition in patients who are malnourished. So do not let CKD patients become malnourished. And I think every good physician should see to it that you allow your patients to eat food. And I think so moderate restrictions should be of the things which are essential, but not necessarily of things. And you should be able to make your own dietary menu for them, help them to navigate through that. You can send them to a dietitian, but train your dietitian into make your dietitian understand what you want out of the patients. So you should do a good talk with your dietitian to make her understand as to what is it that you would want her to talk to your patients and how she can make. She can add, because she can add some alternative diets and make a menu for 5-6 days, which can give them alternative food items which they can enjoy on different days, and which you may not have time to do that. But I feel that still you should be able to navigate your patients into a good nutrition. Is there an effect on, if the blood pressure is not controlled with only ARBs and ACE, so what are the other drugs you will use?
So if the blood pressure is not controlled with the ACE and ARB, then I will move on to calcium channel blockers, diuretics. But considering proteinuria also, that I will write in today's scenario, I would like to consider SGLT2 inhibitors as for the second line after ACE inhibitors.
Yeah, you will reduce proteinuria, but blood pressure control is important. And SGLT2 inhibitors might help you to reduce blood pressure by about 2 to 3 millimeters, or maybe at the most 5 millimeters of mercury. But if the blood pressure control is poor, so you will have to add a calcium channel blocker. I would use a calcium channel blocker. I would prefer amlodipine here again. I'm sort of, these are biases to some extent, but then there is a background reason also sometimes, which as a scientific person you should know. And amlodipine, again, a long effect of single dose of amlodipine, a 24-hour drug, again another drug, 24 hours. So you could use a amlodipine. If you have to use 2 drugs, then use amlodipine in the morning so that it has a 24-hour action, and use telmisartan in the evening and 1 drug. So you could use good dosages of these 2 drugs together for control of blood pressure. Amlodipine, again, is one of the most potent anti-hypertensive drugs, I think, and calcium out of the calcium channel blockers, probably amlodipine fulfills that gap. The only adverse effects, like for ACE inhibitors, is cough in about 30% of patients, which is extremely difficult in some of these patients. And same will be edema, pedal edema, which can be very disturbing. But if you tell your patients, not everyone gets severe edema with amlodipine. Again, 25 to 30% of patients may have edema. Out of them, about 20% may have severe edema, and yeah, you may have to discontinue this drug. But majority of the other patients, mild edema, you will have to tell your patients to accept it. They get worried because they're not able to distinguish whether this is edema related to kidney disease or this is related to the amlodipine. And sometimes physicians also don't want to do it, and therefore they discontinue. But then there isn't as good antihypertensive as amlodipine. Cilnidipine and others are not as good. even in equivalent dosages, you may increase the dosages of cilnidipine or benidipine and other dipines, but by and large, not as good as amlodipine. So amlodipine is a good drug if you can use it, but once in a while or few patients, you may not be able to use it. So use other drugs. So what are the other drugs which you will add?
So after that, diuretics.
Yeah, diuretics would be a good drug. If a blood pressure is not controlled in our patients with kidney disease, then diuretics would be a reasonably good drugs to add. In fact, if you want to use, I usually try to use diuretic before even calcium channel blockers, because they increase the renin-angiotensin, and renin-angiotensin inhibitors and RAS inhibition becomes a better method of controlling blood pressure. So combining a diuretic, small dose diuretic along with telmisartan or RAS inhibition would be a good, and then calcium channel blockers, and fourth drug would be
Mineralocorticoid receptor antagonist.
Yeah, they could be very good. The only problem with mineralocorticoid receptors at the moment is hyperkalemia again in these patients, but they would be again reasonably good drugs, especially if hyperkalemia is not an issue. If renal function is good, then mineralocorticoid would be the other drugs, and then you can go to beta blockers and then alpha blockers or so. So I think that would be the kind of choice of medicines which should be used in patients with kidney disease. These are the kind of choices, number one, number two, number three, based on the mechanism of action and the ones which are involved in our patients as well. So that would be one other thing that you need to do. Anything else you need to do in this patient? After having checked, you should do a good bit of stop smoking. So if he's a smoker, how about alcohol?
Sir, in IGA, they said that a moderate amount of alcohol intake is like a good prognostic factor, but I will not recommend it.
You'll not recommend this? You are a teetotaler or what is it? No, this is again another common question which the patients will ask you is that what would be your prescription for an alcohol, or would you allow them to have an alcohol or not? So I think moderate amounts of alcohol should be. You should warn them that they should not get drunk so that they forget to take medicines. So they should drink that much that they remain sane and remain in good condition, so that they are not able to neglect their disease and their nutrition and other things. So moderate amounts of. Usually, if they start drinking beer and all that, that increases the amount of salt and water and large amount. So I usually tell them, if at all they have to drink a beer, then maybe a glass of beer or would be okay. But otherwise, one or at max 2 drinks taken maybe once or once in a while, maybe twice in a week or so, without the other encumbrances that go along with drinking with your friends, is the tam jam, the kebabs and these nuts and namkeens and all that. That's harmful for our patients. So I think if they have to drink, they should be drinking alone, not with the amount. Maybe a salad here and there, but not large amounts of associated items, which usually many of them drink for long hours when they start drinking together. So you should warn them about those things and not allow them to. But allowing patients, your chronic kidney disease patients must enjoy their lives. They should not deprive them. One is that the disease deprives them of all the joys the moment they get to know, and then on top of it, the food and the prescriptions that physicians tell them, they make it more moribund, and they die even before they actually die. So it's good to allow them to live reasonably well, so that they feel part of the living community and not dead community. And so that would be okay. So once in a while, small amounts, not don't be so drastic that you don't allow them a drink or so. Those who drink occasionally could be okay. So that's smoking. No. I would barter 1 drink for stopping smoking. So So somebody who wants a drink could be that if he stops smoking, then only, and make their wives in charge of this, so that they are the ones who, or children, that they should stop smoking, because they are the ones who would force them once a physician has told them that they should stop smoking. And smoking is definitely out. So I wouldn't compromise on smoking. So don't accept smoking from people. So you can be lenient in other things, but not in smoke. So what else would you do to make them better?
Vaccinations.
Vaccinations. Very good. Very good. Vaccinations. So what kind of vaccinations you usually tell your patients? Hepatitis B,
Hepatitis B, pneumonia,
yes.
hemophilus, and this pneumococcal vaccines.
Okay. How effective are these vaccines in patients of chronic kidney disease, by and large?
Right, sir. They say these patients are immunosuppressed, so the immunogenic response to vaccine could be low, sir, compared to the general population. So that's why sometimes we have to increase the dose. Also, we have to monitor. Also, we have to give booster also if needed, sir.
Yeah. So you should try to immunize them as early as possible, because early renal failure is less immunocompromised than severe chronic kidney disease. So in patients with chronic kidney disease, when you see them at a creatinine of 1.5, 2, that's the time to immunize them. And you should, because their immunogenic response to vaccines is much better at that stage than at a stage of creatinines of 4 or 5 or end stage kidney disease. So, but you should vaccinate them at any stage you see them, because 50 to 60% of them do produce antibodies against the vaccines, and then you may have reasonably protected patients. So I think you should, because these diseases are fairly fatal in many of these patients and produce long-term consequences which could be terrible for them. So pneumonia is one, and you would use 2 doses of pneumonia, Prevnar 13 as well as pneumococcal. And what about after 5 years, what will you do for pneumococcal vaccine?
Have to give a booster dose, sir.
Yeah, booster dose at 5 years. But what vaccine will you use for booster?
13, sir. Prevnar 13, sir.
Yeah, Prevnar 13. Okay. What else?
And then current scenario is a corona vaccine also I will advise.
Yeah, corona vaccine. And what is the response rate of corona vaccine to patients of chronic kidney disease?
I'm not sure, sir, about it, sir.
But yeah, in patients of chronic kidney disease, at least in end-stage kidney disease, people have looked at it and they have a reasonably good response rate. 80 to 85 to 90% people with kidney disease will have. Transplant patients in comparison, or those with immunosuppressive drugs, with glomerulonephritis and immunosuppressive drugs, 50% of them have a response rate. So overall, vaccination response to COVID in patients of kidney disease is reasonably good. So you should vaccinate them. But they might still, some of them may not have enough antibodies and they may need a booster dose. Unfortunately, at the moment, boosters have not been recommended or not allowed in our country, but I'm sure they will soon look at this and probably allow boosters for CKD patients as well as for transplant patients. What about vaccination for herpes zoster and
yes, sir.
varicella?
Yes, sir, definitely that we can also plan, sir, and because he's not like a transplant candidate right now, so definitely we can do that also, sir.
Yeah, I think we should look at this history. There are a lot of patients now who do not get. See, chickenpox was very common in our early stages of life, but there are many children now who don't get chickenpox, and they may be vaccinated in early life itself also. So if people have not been vaccinated and haven't got chickenpox, then they should be vaccinated for varicella. One can look at the antibodies, IgG. If they're not there, then probably one should vaccinate for varicella as well. Yes. Yes. Zostavax would be good vaccine for them. Okay, vaccines. Anything else that needs to be done for chronic kidney disease patients?
Yes.
Exercise. You should also tell them to exercise. Okay.
Okay.
When you use SGLT2 inhibitors, then what are the precautions that you tell or education that you do to the patients? So what are the things you have to tell them?
First, we have to tell them to maintain their water intake at a good level, and then maintain the personal hygiene of the genital area.
Yeah, good hygiene. So they should have personal good hygiene of the genital areas. What else?
Water intake, so to prevent any
Yeah.
dehydration, they
The
should have
volume depletion and all that. So you should also tell them that they will have sugar in their urine. Otherwise, they get worried when they get a urine examination done that they said they never had sugar in the urine. Now they have started having sugar in the. So you should warn them beforehand. And the other thing you should do is the sick day rules, which should be applicable also to RAS inhibition as well as to that when they get admitted for surgery or for any other things, or they are acutely sick, get volume depleted, diarrhea, vomiting, they should stop these drugs for a day or two. Once they get better, then they can restart these drugs again. And that's something which should be done for SGLT2 inhibitors as well. So you should, sick day rules are important. If they get fever, nausea, vomiting, or they get admitted for surgeries and all that, they need to be careful about these drugs because volume changes will cause deterioration in renal function and other things in these patients. So that's important. Okay.
Yes.
Okay. Anything else? Any other questions? I think there were some answers which some of these students have given, and I think they were right. I looked at 25 grams, I guess. Abhishek is saying that is probably the amount of protein in 100 grams of the items that we were talking about, and 4 grams of protein. Probably he was talking about milk, I guess. I don't know. Vivek Goel was saying one. Genital hygiene is another, and chronic disease. How do we explain the normal size kidneys? Well, normal size kidneys on ultrasound don't necessarily. Kidney size doesn't decrease in every person. There are a lot of patients who come with chronic kidney disease. You biopsy them and you have end-stage kidney disease. It doesn't decrease in size in everybody. So don't get, just because the kidney size is normal doesn't mean that the person doesn't have chronic kidney disease. On ultrasound, other features may suggest chronicity of the disease is, but not necessarily the size. Size, if it is there, it helps. But if the size is normal, it doesn't help to rule out a chronic kidney disease. Anyone else with any other questions? If not, then we've passed quite a bit of time as well. So I think time for dinner for you. You must be hungry. Shashank, well done. Good.
Thank you.
Thank you.
Thank you so much, sir. Thank you.
Okay.
Thank you so much, sir. Thank you so much for such
Okay.
an enriching session, sir. Thank you. Good night.